There have been a couple of people who have said to me that they can't attend and are interested in watching the recording. Of course, they miss out on the interactive piece, but welcome back to another Temple Beth Torah lunchtime learning. We had a great time about a month ago with Rebecca Lunstroth from the McGovern School of Medicine, part of University of Texas, who is an ethicist and who helps doctors and the medical school in general learn about the ethics of medicine in many ways. And today we're going to be exploring the ethics of medical economics, which affects all of us, even those on Medicare, those on private health insurance, those without health insurance, and one of the most interesting topics that we can imagine in the medical world. So without further ado, Rebecca Lunstroth.
Okay, so like the last session, I'm thrilled you're here. I want to start with this. If in the chat or live, I would love to know what questions you have, because I can talk about this topic ad nauseum, straight for like 3 hours. I have a huge interest in this. I hobby in health policy, and I've tried to, I am a learner of like, how did we get here? And so I would love to know like what you're interested in knowing, but let me try to wet your whistle a little bit and give you just a really short, I actually have a presentation, a really short presentation of kind of how the United States ended up with the system we have. Okay, so are we good with that? This is going to be like 5 minutes, 10 minutes. And so I'm going to share my screen if I can. I can't. Can I? Yes, I can. Okay. Rabbi, I need you to do something. You disabled it?
Yeah, no, I just made you a co-host, so you should be able to share your screen now.
Okay, can you see this? Okay, you can.
I can see it. Can everyone else see it?
Okay, so guess what? We're going back to 1983. You're like, what? Wow, she really went back. And really, I start here because Germany was the first country to create a unified health insurance system. And again, this is going back to 1883. And I highlight it for a reason. In 1912, there was a committee assembled in the United States. It was called the Committee to Explore Social Insurance. And this was on the heels of some successful workers' comp legislation that was passed. And the idea, the current thinking at the time was, okay, great, we're taking care of folks who were injured on the job, but what about those who get sick naturally? What about them? And I also want to note that this committee, this was not a government committee that came together. These were private individuals, which is something else that, keep in the back of your mind when we talked about this. So a couple of things happened with this committee. First of all, there was a lot of concern that any type of unified healthcare system would impinge on the physician-patient relationship, such as it was back then. Secondly, and I think what's really, really important to note is that in 1912, the cost of healthcare wasn't so great. In fact, there wasn't even that much healthcare. And if you look at some of the history around healthcare back then, I mean, we did have reforms had taken place, but there's some really interesting quotes about you are more likely to die in the hospital than out of the hospital. I mean, that's how rudimentary healthcare was at the time. And it didn't cost a lot of money because it was low tech. And I would take you back to like some of those famous photographs where you have the wise old physician looking over the sick person. And really, that was all the support they could lend, was them being there. There was really not a lot of medicine. And so there wasn't a burning platform, if you will, around the cost of healthcare in the early 1900s. And then thirdly, and what's really interesting and why I bring Germany back is there was a lot of anti-German sentiment at this time. And so there was anything the Germans did, we ran the other way. And so there was no appetite for following anything that had anything German to do with it. So that was the first attempt to think about having a unified healthcare system. And then I just want to, in insurance, so there was no health insurance at the time, but we had disability insurance and we had life insurance. And when you think about insurance, it has to be predictable. It has to include everyone. And this idea of health insurance was just, people could not get their head around it because sickness seemed very random, very unpredictable. So how would you put actuarial tables together for something that was so utterly unpredictable? And again, the idea that, well, we're not talking about that much money, and there was absolutely no data to support any kind of insurance scheme. So that's just a little insurance 101 there. And then in 1929, again, private individuals in Dallas, Texas, of all places, put together the first insurance scheme. And what they did was they went out, and it was to the Dallas public school teachers. And they said, you know what, if you give us a very nominal amount of money every month, we will pay your hospital bills should you need to. And there was a lot of skepticism because, again, there was absolutely no historical data or precedence for this. And what's really interesting is, like, shortly after about 35, I think, teachers took advantage of this. Shortly thereafter, one of the teachers was hospitalized and her bills were paid. And so this was the first insurance scheme that we know of, and it was coined Blue Cross Blue Shield. And then right on its heels was the development of prepaid plans. And we don't have any of these in Houston anymore. We used to. It was called PruCare. That's Prudential did it. But these are your health maintenance organizations. So you pay a nominal amount and all of your healthcare needs are taken care of. And so the biggies of this, the Kaiser Permanente is really the big player in this market. And the AMA actually filed suit against the early plan, saying that, again, it was an interference in the patient-physician relationship. But you can see there are a bunch of prepaid plans out there. So by the early 30s, by the 1920s, we had both Blue Cross Blue Shield and these prepayment plans. So in 1943, we had World War II. And this is pivotal because what happened then, some of you may, none of you remember this, but okay, history again, in order to stabilize the wartime economy, Congress imposed wage freezes. And so corporations were not allowed to give their employees increases to stabilize that economy. And companies got very creative and said, could we offer benefits in lieu of providing wage increases? And Congress said yes. And so folks, very serendipitously, this is why we have this private employer-based health insurance scheme in the United States. It was a historical fluke, if you will, that made this happen. And then on its tail, Congress also passed very favorable tax legislation, essentially allowing companies to exclude any monies that they put into these health plans from their taxable income. It is today the hugest tax break ever given to American companies. And again, it was all a fluke of history, if you will. And so let me just go back to here. And so the early plans, the early Blue Cross Blue Shield plans used something called community rating, meaning that everyone in the community was charged the same rates, regardless of whether or not they had a pre-existing condition or their health status or usage of health care. And so after the employers got involved in giving health insurance, private health insurance companies that heretofore had said, do we really want to create health insurance plans? They realized that they could go into companies with younger and healthier employees and provide health insurance premiums cheaper than the community ratings. And so here again was where we got into a competitive health insurance market, because Blue Cross Blue Shield originally was a nonprofit organization. And so any money that was made went back into the organization and not to shareholders. And I would ask you to compare and contrast this to private insurance companies who have a legal mandate to provide stockholder value. So it's all about them making money. And since they were able to provide better rates to many organizations, it completely turned this idea of community rating on its head. Everyone knows who this is. I'm not going to play you this recording. We don't have time. But in 1961, there was yet another movement underfoot. It was actually started in the Truman administration to, again, explore this idea of some sort of universal health care for Americans. And Ronald Reagan was an actor at the time, and he was employed by the AMA to speak up against any type of uniform health care plan. And so I have this recording here, and if we have time at the end, it's really quite remarkable to hear him talk about this in the early 60s, that he was the spokesperson for the AMA against any type of universal health care. We're not going to listen to that. In 1974, and again, this is kind of getting a little wonky on you, but it's suffice to say that health insurance is governed at the state level, and each state has their own rules and regulations around how healthcare is dictated. So for example, let me just give you an example. So in all but 5 states prior to the ACA, health insurance companies could exclude people with pre-existing conditions from ever getting health insurance. And that was at the state level. Now, there were 5 states that said, no, you can't do that. You have to write a plan. What ERISA did was there's very large companies, and I'm sure some of you have worked for them. They are largely self-insured. And all they do, they pay all the bills, right? So they're assuming the risk, because health insurance companies, that's what they're in the business of, is assuming and managing risk. Employers who agree to be self-insured assume that risk. And what ERISA did was said, okay, companies that assume this risk and are self-insured, you don't have to follow state health insurance laws. You can do whatever you want. So for example, if a state says that you have to cover, let's say, the mental health of anyone that you write a policy for, ERISA says you don't have to do that. You get to write your own rules. So again, another fluke in how we legislate. And this difference between self-insured plans and state plans. So that happened in 1974. Oh my God, how did I forget to talk about this? It's not employer-based health insurance, but as you know, in 1965, Medicare and Medicaid were legislated. And this was huge. These are both entitlement programs, meaning if you meet the eligibility requirement, you automatically are entitled to those benefits. Now, it's so interesting to look at the difference between Medicare and Medicaid, because Medicare, care for the old, was based on this idea that old people had earned the right to health care. And if you look at why it was even passed, it's because if you look at how health insurance works, these are not easily insured individuals because they have pre-existing conditions. And so again, they had paid their dues. Now, I think it's also important to note that physicians got rich off of Medicare. Pre-1965, physicians made a very healthy living, but with a guaranteed payer in the federal government, their incomes went screaming up. Now, in contrast, Medicaid was the plan devised for poor people, and it was never thought that people would be on it long term. It was thought that people would cycle in and out of employment, and for times that they cycled out, Medicaid would be there, but really they would be in some sort of employer-based health insurance. A report was in the paper today. 25% of all Americans receive their health insurance through Medicaid now. 1 in 4 people, which is Medicaid or CHIPS. There's a children's health insurance program for people that increase the eligibility requirements for children. That is huge, but it's suffice to say it's marginalized. So the reason I want to bring this in is these are nationalized plans, right? I mean, we don't have a single payer system, but we've got a system where over, let's see, if you add Medicare and Medicaid and the VA, upwards of almost 50% of Americans get their healthcare through government plans, which is crazy when you think about it, because we say we have this private system, but we really don't. And the government funds a huge portion of this healthcare.
A quick question, Rebecca.
Yeah.
Because you said it quickly and I wanted to make sure I understood. You said I think you said in 1965, when Medicare and Medicaid came into being, that was a time when doctors' income skyrocketed because a lot of their income was coming from the government?
Yep. Okay, let me go back for a second because it's part of the economic system of our healthcare system. So again, private insurance companies, which is why I want to focus on private, they are in the business of making money. Okay, they really, again, they're private corporations. And so they have a fiduciary responsibility to earn stockholder value for to provide value to their stockholders. Part of providing value is denying claims. So they make it, for those of you who have been denied a claim through your health insurance, you know how difficult it is to get that overturned. And they do that intentionally. I mean, because they make money doing that. Whereas the government, if you follow their rules, they're going to pay. So that's why they made, because there was this guaranteed payer in the federal government, and there was no haggling over whether or not something was covered. It was very obvious whether something was covered. And the reimbursements in order to get organized medicine on board were very generous initially. That's not the case anymore, and I'll be happy to talk about that. Did that answer your question? Okay, then as you know, the ACA was passed. The recent lawsuit didn't hold any water because the plaintiffs did not have standing, which means they did not have any interest, or they had no harm under the law. And so the ACA is still the law of today. And the ACA had one big objective, and that was to get healthcare in the hands of more people. And it largely succeeded. And it was not done very innovatively. All they did was really blow up what we already had. They made large employers, they required large employers to offer private health insurance. In response, employers made a lot of employees part-time so they wouldn't have to provide health insurance. And then the other side of that was the expansion of Medicaid. Now, the interesting thing about the Medicaid expansion was that, I'm going to stop sharing here for a second. The other really interesting thing about the Medicaid expansion, so the idea was that everyone, all poor folks should have access to insurance. And the government said, we want to do this through expanding Medicaid. And Medicaid is a state federal partnership. And the federal government provides there's minimum requirements of who must be covered under Medicaid. Now, states have the flexibility of expanding that, and many more progressive states have done that. States such as Texas only provide the minimum. So the idea, and so in Texas, if you're an adult without a disability, you will never qualify for Medicaid in this state. So the idea was to expand it to all indigent citizens of the United States. Now, in the Supreme Court decision that affirmed the individual mandate, that same decision said that the states could not be forced to expand Medicaid. So what we have are 12 states, including Texas, who's chosen not to expand Medicaid. So, that's what happened under the Affordable Care Act. It largely did what it set out to do, although I could speak volumes of where all the holes were in it. Probably the largest hole is who ran to apply for insurance when the ACA, when it was first made available to folks, not under Medicaid, but under these exchanges. It was largely people who had been excluded from the private health insurance market because of pre-existing conditions. So the people enrolling were largely sicker than the average population. And what that did was it drove premiums up. Now, the other thing that happened is initially all the health insurance companies wanted a piece of this new market and of all these new people. And so they actually offered packages that were underpriced. And so because they wanted to bring you into their health insurance market. And so what you had converged was prices that were below normal and people who were enrolling who were sicker. What happened? Prices went screaming up. And actually in Texas, what happened was most of the private insurers left the market because they did not think that they could earn a decent return by staying with it. So what we have, folks, is this really schizophrenic system in the United States. I can't think of any other way to put it, because we tout that we have this private health insurance scheme, but in reality, over 50% of all Americans have health insurance through the government, either Medicare, Medicaid, or the VA, while the rest have private insurance. Or we still have, about 13% of all Americans. I think it's gone down since the Biden administration, but we still have a large percentage of Americans who don't have insurance. So we are in a system where it's all about making money. And I think what I'd like to talk to you about, especially with the physician in the room, is the issue of to what extent should healthcare be run as a business? Because it is absolutely run like any other big corporate entity out there. And one of the ethical issues is, well, should it? And how do we even change that if we want to change it? So I would love to know your thoughts. I'm going to shut up for a second. That was longer than I intended to talk. What questions you have, thoughts, anything?
Well, one of the things I think about, if we don't have health insurance run as a business, then one alternative is for the government to run it. And the way the government runs things in general, I just don't know that that would be a better system.
Okay, so that is I think that's a great observation. Although Medicare and Medicaid run pretty darn efficiently.
Except for all of the corruption. I mean, it's a hard system to monitor.
Well, and there's corruption in the private system too. I mean, if there's money to be made, people are going to find a way to make it illegally. But I know, I totally agree with you. So folks, here's what's really interesting. If you look at how other countries do it, there are a host of European nations. Germany is one of them. France is one of them. I mean, actually the majority, no, I don't know if it's the majority, but a host of countries in Europe actually use private insurance as their mechanism for their single payer systems. And the way that they structure these, and I think we're just too stupid to do so. It's too complex for us to be able to convey how this works. But if we were going to do anything, we already have proof that this can work. And so these companies, the way they monitor it, now, the other thing is all of these companies, all of these countries also have global budgets. And so they put a cap on how much money can be spent, which is something we as Americans are not willing to do. Even though we ration care, but we ration it based on socioeconomics. These other countries also ration care, but it's on a much more egalitarian basis. So the way it works with insurance in these other countries is these private insurance companies cannot make a profit off the basic plan that all citizens are required to have. And what they do is they compete fiercely on supplemental plans. So, and again, each country has a different scheme that's really congruent with the cultures of those countries. And again, I think in America, we need something that's congruent with our culture, which is using the private market. So Lynn, I agree with you. I mean, we're never gonna go to a single payer healthcare system. It's not who we are as a culture. But again, these other countries, they have health insurance plans, but they just say to these private companies, you cannot make a profit off of these basic products that everyone must have. So there is a way to do it using, and the other thing is, I keep interrupting myself. The other thing is we're not going to eliminate an entire industry known as health insurance. Again, it's just not going to happen. As much as I would love to see it happen, it's not going to happen. And so we have to find a way to work within the system we already have. But that would mean reduced profits to the health insurance companies if we went that way.
Would you address the difference between the United States and Europe, for example, where we feel that healthcare is a privilege as opposed to a fundamental right?
You're absolutely right. And again, I think this is part of the culture. Each country has come to it very differently. You know, again, Germany in the late 1800s and, you know, countries, England right after the war, World War II. There is much more sense of, okay, I'm trying to think the word I want. These other countries, I mean, they're social democracies, and so they provide a lot more benefits to their citizens than the United States does. We are kind of we have a libertarian ethos in this country, meaning that the free market takes precedence almost over anything, whereas in the rest of Europe, that is not the case. So that's the major difference between the ideologies of these different democracies. You know, most of Europe being social democracies with much more generous welfare benefits. Did that answer your question?
Yeah, I was just curious about the genesis of that difference. And as a follow-up, is there a difference in the quality of care, in your opinion, between what we provide in the United States under a libertarian system as opposed to a social democracy?
Great question, and I'm glad you asked. And I think this is the toughest pill to swallow. We spend almost twice as much as the country that spends the second most. And here's the tough thing is our outcomes do not justify it. And I don't have the statistic at the tip of my tongue, but I want to say something like 30% of all medical care is unwarranted. So I think that's, in this kind of libertarian ethos that we've got, like this do more does not actually mean better outcomes. And the only disease state in which the Americans perform better is in some cancers. That's it.
That's a very interesting statistic about how much medical care is unnecessary. When Pierre's asking about the quality, my guess and my assumption is that there's a better quality of healthcare for people who are able to pay for it than for people who are not less able to pay for it. My question is how to balance the, Pierre used the word right. Do we have a right to healthcare? How do we, if we assume that we do have a right to healthcare, how do we balance that with the right to make a profit? The right for a skilled physician who has a lot of training to make the kind of money that he or she has earned. The right for excellent administrators to be able to make money administering it without it being an abuse of the right for people to be healthy. Is there that balance between being able to have a system where people make money on healthcare and people are healthy? My analogy, I'm thinking about cars. People who sell cars make a profit on it. They need to be safe and they need to be quality, or else people aren't going to buy those cars. So how do we have quality healthcare that isn't superfluous? My guess is that what you're saying about medical care that is unwarranted, it sounds like that's just to make a profit, that people are diagnosed with procedures that they don't need. I guess I'm asking a whole bunch of different things.
Well, I mean,
If I could,
go on, Hi.
I just retired, but I had a partner that would order this and that, and I'm not saying anything was wrong with it, but he would order so many more lab tests, so many more procedures than I would, where I would take an approach, well, why don't we watch and try this before we do that? And then if we're not getting anywhere, and you can start just at the beginning. I mean, one of the things that, I used to do with my medical students when I was a resident is I would go to the finance office and take one of the patients that we had taken care of and get their medical bill, which was about this thick, with a 2-week stay in the hospital. And they would see all these tests. They would, we would sit in our reports and go, well, let's order this, let's order that, let's order this. And then all of a sudden there was a price tag by every one of those items. And we would talk about, do we really need to do the same test 2 days in a row? And, you really have to think about, at least from a physician level, what you are doing every time you do something. And we would look at the bills. And I mean, one of the bills was for these booties that every patient got, these like socks that have little skid things on the bottom of them. And they were charging like $20 for them or something like that. And the patient didn't use it. And we went back to the billing office and said, here it is. This is the piece of merchandise that was not used by the patient and they got billed for it. Can it come off the bill? And, just so many things are charged for and so many things are ordered that are probably not necessary.
I thought those booties were a free gift.
Nothing is free in healthcare.
Nothing is free. So Dan, I mean, you asked like a ton of different questions, right? And I think, we could go a lot of different directions on this, but I think one of the biggest challenges that we face right now is that so many different groups have a vested financial interest in how it's done, like in the current system, right? And from start to finish. I mean, billing, I mean, we have professional coders. I mean, that's a job that people perform now, is coding medical visits. But there's a vested interest in there. And so when we think about reforming our system, whose money are we going to mess with? What pie are we going to reduce or restrict the growth of? And that's where, the lobbyists come in, who are very effective. And so it becomes a battle of wills. And again, the politicians get a lot of money from these different interest groups as well. And so, changing that is really complicated because no one wants to take a pay cut. I don't want to take a pay cut.
So if they were to ask me, do you want a pair of socks for $20? And I decline, then I'm cutting into the sock manufacturer's income.
America, right, who I'm sure have a lobby. So, and the other thing that's really interesting is in healthcare, and again, I can talk about this, we're supposed to get approval for almost everything. But, once you go into a hospital, you don't ask, can I take your daily labs? Do you want, can you imagine, and I've done this, so I can't imagine it, but imagine the next time you or loved one's in the hospital and, they want to wheel down, you're like, oh, I don't want that test. No, I don't want those labs. Can you imagine if what that would set up? I mean, first of all, that's the other problem. And I would argue that medicine doesn't operate in an economic model because there's this huge power, or not information imbalance. I am there because I can't fix me. And so I am looking for someone else to provide their knowledge and tell me what I need. I'm not in a position to say, do I need that test? Do I really need, I'm not in that position. And that in a traditional economic model, there is free, like everyone has the same information in order to make decisions. And that does not exist in healthcare. It's why physicians go to school for so long, because they have a body of knowledge that the rest of us aren't really even wired to obtain. So Debbie, I know you had a question.
Actually, it's a whole group of things. European model. My son went to England a number of years ago, had a horrible earache, and they told him 2 to 3 months before they can see him. He ended up seeing somebody private on Harley Street. I've spoken to Canadians, I'm from upstate New York, who come to the United States because they have to wait so long to get health care. The Prime Minister of Canada came to Cleveland to get his medical care because he wasn't getting it in Canada. The other thing that concerns me is it seems that a lot of this turns into rationing. And the people who get rationed out are those people perhaps who have orphan illnesses and people like me who've been on Medicare a number of years. And so reach a certain age and they say, well, maybe you don't need this and maybe you don't need that. And finally, Kingwood Hospital charged me $16,000 for a test. Medicare paid about $1,000. If I was a private payer, I would have to be fighting about that $16,000 forever. One charge is ludicrous, but the payment Medicare made for that $1,000 for the 16th is also ludicrous. I look at what Medicare pays my doctors, what they paid for tests. I don't see how doctors can survive on that. And when you talk about Medicare for all, and this isn't original with me, it seems that a lot of doctors will have to close up shop. A lot of hospitals will not be able to survive on what Medicare pays for something. And final thing.
Oh, God.
Yeah.
That's okay. I'm writing this down so I remember.
Okay. Final thing is, it seems like a lot of the tests that are given are sort of covered your butt type things. You don't want to be sued. And so you order a test and another test. My pulmonologist wants me to take a secondary test to see if it's the same as the first test. And I'm deciding I may not do it because I really don't see the point. Well, there is some point, but is it enough of a point? So I think a lot of this unnecessary things that happen in medicine are really because the doctor's afraid to be sued, which happens far too often.
Okay, so I want to address each of those points and let me know if
Okay.
I don't. So the first thing, rationing. Okay, you are absolutely right. Every single country that has a unified system, healthcare system, explicitly rations. They have to. They can't afford to give everything to everyone. Okay, I would ask you to contrast that with the United States that also rations, but we do it very implicitly. So we don't tell you we're rationing until you're there and realize you can't get something. And we ration based largely on socioeconomics. And it depends on what health insurance plan you have. That's how we ration, okay? Is one better than the other? I would ask you. And again, it goes back to, I think, what Pierre asked about the culture. You know, what these policies are really aligned with the culture of any country. And so the culture in our country is those who have get, right? And those who don't, oh well. So, you know, again, how we ration in this country, I think, is very aligned with who we are, what our political philosophy is. So that's with rationing. And you're absolutely right. The Canadians, they have to wait, as do, it depends. Each country has, no healthcare system's perfect. Each country has its own challenges. They're all being challenged with costs. I would also ask you, I was going to say this before, I would ask you to think about healthcare on a bell curve. And on the left side of that curve are people who don't have access to healthcare, whether it be that they don't have insurance or they live in a remote area. They may have insurance, they can't find a provider. And they die because they don't have that. Unique to the United States, on the other bell curve, are people who get too much healthcare. Because of the system we have now, yes, we are going to test you for everything, give you everything, et cetera, et cetera. And guess what? That may be detrimental to your health. And so there's a small portion of folks on the other side of the bell curve that are actually harmed by having too much healthcare. Okay, the second point around Medicare reimbursements. Okay, I wish I had something else to show you. So there is something, and the Trump administration, to their credit, attempted to do something about this. Each hospital has something called a charge master. And a charge master, I swear, the hospital executives, they all go to Disney World every year, and they go to Fantasyland, if that's still a land, and they make up the rates that they would love to charge people that are based in absolutely fantasy, okay? The only people that ever pay those rates or charge those rates are the uninsured and people who come here from other countries. They do pay that charge master rate. The other huge cost in our healthcare system is that every year, every entity that takes health insurance, whether it be a private physician's office or the biggest hospital system in a country, they go through this weird negotiation dance with every health insurance company as to how much reimbursement they will accept for every single procedure. Now, let me go back to Medicare for a second. When Medicare was first implemented, in order to get all the stakeholders on board, their reimbursement rates were very, very generous. The government realized that they could not sustain this, and in the 80s, they developed something called prospective payments. So every single thing, and this doesn't apply to pediatric care, but it applies to all adult care. So every year there's a Medicare advisory board that establishes rates for essentially everything. Like if an ostrich bit your right arm, I'm not kidding, there is a rate for that. And so that's the Medicare rate. Private insurance pays greatly above that rate. And you are absolutely right that if there wasn't private insurance, most physician practices and hospitals would not be able to sustain their practices or their hospitals. However, I think the question is, what is the most reasonable rate? And this negotiation that goes on every year costs money. Like, that's one of the weird hidden administrative costs in our system. And so when you get a statement of benefits from your health insurance company, there's going to be the charged amount, and this is the charge master. This is the price that, again, only foreign people, foreign visitors pay. And then you have the negotiated price that your insurance company and provider agreed upon. And then you have that delta of what's not covered that you were talking about.
Mhm.
The private insurance, again, pays for, that charge master rate, which the Trump administration said all hospitals have to publish it, it's Greek. No one can really understand it, but that was one of the transparency things that Dan mentioned, taking the mystery out of it. But the rates that are established, those heretofore have been proprietary between what the health system can charge and what the insurance company is willing to do. And as you'll remember, every year or two, there's always a schism between a big hospital system and a health insurance company that they can't come to an agreement. And it's over what those reimbursement rates are. But Medicare is kind of that 100% bar. Okay. Lastly, I just want to touch on one other thing you said, and that is around medical malpractice. And I do have a lot to say about this. Texas legislated one of the most aggressive tort reform packages in the country in the early 2000s. And it limited those punitive damages that juries like to award for, because you were a bad actor to, oh my gosh, I should have this off the tip of my tongue. I lecture about this all the time. But they're capped. Monetary damages are capped. And what happened when that legislation was passed, it was opposed by the trial attorneys because they made so much money off of it. It was no longer in the financial interest of trial attorneys to sue doctors and hospitals. And so the number of lawsuits just went screeching down. What didn't happen is we still practice defensive medicine. That has not changed one iota because of tort reform. But we have been protecting doctors in this state for quite a while now. So, okay, I think I answered all your questions. They were great questions.
Great, thank you.
I have a question.
Yeah.
Just as an example, I'm a nurse, and we had one patient at one point who was in her 90s. She was blind, she was demented. She lived in a nursing home. She was on dialysis. An ambulance took her 3 times a week from the nursing home to the dialysis unit and back. And do you see anything at any time, or if this is last night on the news, there was a story about a miracle baby. The baby was born at 5 months.
Yes.
Something like weighed less than a pound. And it was in the neonatal ICU for 6 months. And these are just 2 examples, but will there ever come a point where the healthcare system in this country will address rationing, if you call it rationing, based on a situation? You can't pay for everything.
I would love to know what everyone thinks. Do you remember death panels? Sarah Palin and death panels when the ACA was being negotiated? This idea that, oh my gosh, we're going to reimburse physicians for having end-of-life discussions with their patients.
Now, this particular family, the woman who was on dialysis, she had come into the hospital and the physicians had that discussion with her children that, this is probably the time and the children refused.
Okay.
So they kept right on going.
Okay. So, and I just want to add, because this is where I come in as a consultant, because I do ethics consults, where you've got the healthcare team who is in moral distress. Like they're thinking, what are we doing? What are we doing? Like, what is the end game here? Like, this person's health status is never going to improve. What are we doing? Now, from a Jewish standpoint, Rabbi Gordon, actually Jewish halakhic law actually has a lot to say about this, and is in real conflict with how I think it should be. What do you think, folks? Should we start looking at rationing healthcare? I can tell you, European nations, this is one way they ration. There is a weight limit that, any babies born below a certain weight are not given heroic treatments. And likewise, for many conditions, we're not going to keep you on aggressive measures. We're going to allow you to die. I would love to know what y'all think about this, because most healthcare bills are accumulated in the last 6 months of life.
I have, but I hope everybody has, my written wishes in case I'm in that state. And I'm one of those pull the plug people. Just don't keep me alive for the purpose of keeping a body going. But I think what would happen is if you have that cute 2-pound baby, and then the parents go on TV and they start crying about how they've waited 5 years to have a child, they may never have another one, that people in the United States, being as nice as we are going to want to save that baby. Not the old lady on dialysis, because at a certain point we don't look cute. But I think Americans want to do everything for everybody, and that's going to be a major factor.
Yeah, I think you're absolutely right. I would love to know what others think.
Let me ask you a question. I'm remembering at one point, I think it was the state of Oregon, had a list of conditions.
8 states allow for death with dignity, which in otherwise is physician-assisted suicide. Only 8 states.
Actually, that's not what I was going to ask. The list that I was thinking of, they had a list of conditions that would be funded.
Okay. Okay, so this is absolutely fascinating. So Oregon, remember I said that there were states that chose to expand Medicaid pre-ACA to more people. Oregon was one of those states. But Oregon, in their wisdom, realized, wait a second, we can't cover everything. And so they led a very public initiative to gain public input into where is the line? Where do we draw the line? So if you have a disease or need treatments that fall below the line, Medicaid will not pay for it. And they will, however, they will pay everything above the line. A brilliant way to engage their citizens. And it mostly worked until you had a condition that fell below the line. So, I mean, it was a really interesting social experiment, but it gets to the point that we can't pay for everything. We can't. We're pretty soon, healthcare is going to consume 50% of the federal budget. And there's some economists who say, okay, what's wrong with that? And then there's other economists who say, well, we may not have streets in which to get to the physician, right? I mean, when you think about all the other public goods that the federal government is responsible for funding, you have to balance it out. So I think what Oregon did was really innovative, very innovative.
So they're not doing it anymore? It didn't work?
They did it for a while, and I do not know where it ended up.
But did you have people, let's say, going to Washington if they were ill instead of Oregon?
Well, again, this was under Medicaid. So these were people who didn't have private insurance.
Mhm.
And so they would not qualify for Medicaid in those states. And Oregon had a more liberal Medicaid policy.
It relates, so, you know, as your mind goes from one thing to another, and you were speaking about, with Lynn's question, you were thinking about the physician-assisted suicide. It does relate to when Rebecca and I were talking about what different topics would be interesting. End-of-life issues was sort of the next one after the economic issues, because things always relate to each other. Sort of connected to this, and just to throw a little bit of Talmud into it, is that there's a Talmudic piece that says, when you're reach the end of your days, you'll be asked 6 questions. And high up on that list of 6 questions is, were you honest in your business dealings? I don't think we're ever going to get to the place where medicine isn't a business or healthcare isn't a business. There's lots of businesses. Running a synagogue is a business. And we try and run a synagogue in a moral and ethical way. Selling cars is a business. When you describe how Debbie's $16,000 procedure cost Medicare $1,000, would have cost a health insurance company $7,000, and would have cost a foreigner the full $16,000. When I sold auto parts, we had mufflers that cost $35 to the retail, $28 to the gas station, $10 to the wholesaler, you know, and those are the ways that profits are made, and profits happen, that you give different rates to different people, and not everything is fair. The honesty piece, I think, is essential here, where you're selling $20 booties or ordering unnecessary tests. And what you said before about our knowledge or our ignorance, I don't know that I don't need that test. And so if a doctor tells me you need that test, I'm going to take that test. You know, and then we get the mystery of the procedure happened, and we've got a fee from the anesthesiologist and the fee from the, you know, from the administrator of the drugs. So there's a whole mess of things that fit into it. And I guess that the ethical piece comes up with honesty.
But Rabbi, isn't there also, I was on a panel with an Orthodox rabbi years ago, and we were talking about a lot of ethical conundrums. And one of them was discontinuing life support. And if you'll remember, there was a really tragic case, Jahai McMath. She was a 13-year-old who, following a surgery that went amiss, she was dead by neurological criteria. Her family could not get their heads around this. It was taken to the state courts, and the state courts said that the hospital had every right to discontinue healthcare because the person was not living. Well, in a bid to the Orthodox communities in New York and New Jersey, they allow otherwise dead people to be kept on life support. And so this young lady and her family, this dead young lady and her family were transferred. They moved to New Jersey, where she remained on life support until 2 years ago, when she finally died of cardiac arrest. But this idea of keeping otherwise dead people alive, I was aghast. And again, it was a nod to the Jewish communities in those 2 states. But this idea of life above all, like you don't discontinue life support ever, I find really problematic.
Well, Jewish philosophy does not agree on everything. And the concept of life is sacred regardless is there in Judaism. The determination of is that the compassionate thing? Now, as Debbie was talking about, when it's your child or when it's your loved one, then it becomes a very personal, difficult decision. There's a story in the Talmud about a very well-respected rabbi who was very ill, and his students were all praying for his survival. And his wife was seeing how much he was suffering. And the wife tossed a clay pot on the ground, and it made a big noise. And the students were all distracted from their prayers. And in the moment when the students were distracted from their prayers, the Holy One took the rabbi to death. It's this story about what are we praying for? And the wife who loved her husband and saw that the student's prayers seemed to be keeping him alive and saw that he didn't want to stay suffering, did something against it. And so there's conflicting teachings all over the place. And those rabbis in New Jersey found a teaching that fit what they wanted to happen. And so it's very, that's why we study, and we grapple with the different responses and the different opinions and things like, in terms of the Orthodox community has made a big shift, not 100%, but many in the Orthodox community has made a big shift about organ donations. That initially, for a long time, an observant Jew was not permitted to donate organs because of the law that says, don't desecrate the body. And many in the Orthodox community have said, yeah, but look at the one that says save a life. And so when we get into Jewish study, there's rarely one way to do it.
Well, I mean, it was interesting in this little panel. It was this debate that we had. He was like, please don't ask me this. I'm like, what do you mean don't ask you this? He's like, because it's not going to look very good. I'm like, whoa, hold off. It was really interesting. But I mean, suffice to say, and again, I think, the big question is how much money do we want to put into this system? And I have argued in different forums that, again, medicine does not operate like other goods and services. And I think what's most profound about that is no one wants to be sick. It's not something we want. Usually when you think about utility, it gives us pleasure. We go out and buy goods and services that give us pleasure. Medicine is not, we need it. We engage in it because we need it, not because we necessarily want it. So again, another aspect of healthcare that does not fit neatly into this, economic model. But again, the way we've ended up with this system, again, was very serendipitous through some of historical events and just continued kind of to build on it. And now we have this, the medical marketplace, which is huge, powerful, and, again, with many competing interests. And so getting a hold of all of these and getting folks on the same plate is really, really difficult. The other part of the ACA, I didn't even touch on this, but, there was they had three primary objectives. One was enrolling people, getting more people health insurance, which they were successful at. But the other two, improving quality and reducing costs. The quality stuff has gone somewhere, but the cost stuff, We just cannot get our heads around that. And so I think to Debbie's point, Medicare is kind of the bad guy in the room because they're the ones, they're the payer, they're the largest payer. And so, yeah, they are trying to reduce their liability. And they can do that. I think it's also worthy to note that when Medicare is successful at doing something, private insurers follow suit. But again, there's this weird negotiation that takes place every year. And a hospital can't afford to lose their major insurer, and the insurer can't lose their major hospital. And so you've got this weird thing that goes on every year that comes up with that negotiated price. But lots of people making lots of money in this system. And we have not been able to figure out how to reduce that burden.
Well, we've got a lot of things to continue to figure out. We're past our 1 o'clock time, but I want to thank Rebecca. And we picked this topic as because healthcare affects everybody. When we think about ethics, to be able to bring those thoughts into everything else we do, how do our ethics affect how we run a synagogue, how we run our personal businesses, how we run our families? That when we look at the difficulties in ethical healthcare, to also look at all of our ethics and values with whatever we do in life. So thank you so much, Rebecca, for bringing your openness, your wisdom, your expertise, and your willingness to engage in some of the many difficult questions. I invite everyone to come to our Zooming service every week, every Friday. This Friday we'll have me, and then I'm going to go on a little bit of a vacation. And a week from Friday, on the 2nd of July, we'll have Janice Rubin. And every week there will be a special guest to help us experience different ways to worship Shabbat. Any other closing thoughts? All right, thank you everyone for coming and engaging, and we look forward to more learning together. Thanks so much, Rebecca, and everybody else.
Thank you, Rebecca.
Everyone has to wave because that's, Bye, y'all.
Bye.